So, once again, welcome you all for this very awaited evening because after such a long time, we are restarting this program in this very new year. And once again, thank you very much for joining us. For those who are new to this program, let me first introduce about this program. This program is it is an online forum. The BRENDOS is the Breast and Endocrine Society of Western UP. I hope my voice is audible to each and every one of you. So myself, Dr. Sudhi Agarwal Kambuj, I'm a breast and endocrine surgeon, and this forum was started by myself around 3 years back with the purpose of creating more and more academic awareness about breast and endocrine surgical related disorders so that we become uh, a better version of ourselves in this field. This is a Breast and Endocrine Society of Western UP because I work in a Western UP. So we started like this, but we have a pan India impression because we have faculties, we have participants from all over the country. And on a regular basis, we discuss about breast and endocrine related problems. Where on every even month, we discuss about the breast problems. Every odd month, we discuss about the endocrine problem. On every last Friday of the month, and it is an online program, so from the comfort of your home, anyone can participate in this program and can learn from the experts. So there are various formats through which we run this program, one of which is the case presentation, where we pick a clinically challenging case which we see in a day-to-day practice, and we pick one such case, we discuss about that case in detail with actual images, radiology, pathology, with the help of the experts who actually manage that case, so that we learn the maximum from them, their perspective, how they decided, what type of management, we learn everything from them. And today is such day where we are going to present a very, very interesting, though challenging case, that is the anaplastic thyroid cancer. So before I start the program, first of all, I would like to thanks my friend, Dr. Sushant Rohila is with us. He is a very senior dental surgeon. Right now, he is a principal prosthodontist and implant dentist in South Wales, Australia. We were friends since our KGMC days. And there are a few disclosures which I would like to present before I actually present this case. Is that this case is not managed by me or my team. This case was managed by Dr. Amish Vohra, who is a medical oncologist, and his team. But Sushant, being my friend and I being a thyroid surgeon, he discussed this case with me, which I found quite interesting because so many new investigations, new therapeutic agents were being used in this clinical scenario in this patient, which attracted my attention, and I really craved to learn most out of this case through BRENDOS, right? So thank you very much, Sushant, for giving us this opportunity. And thank you for joining us. I hope most of your questions will also be answered in this program. Few of our faculties are still finding some technical problem, but since we are running out of time, so I've started this program, and I hope my team is in constant touch with them, Dr. Sabha and Dr. Arvindan sir, whom I really want to join because I really want to extract most out of their intelligence, out of their experience, and my team is constantly in touch with them to sort out the issues. I hope by the time we are presenting, they will join us. So now, if I formally start this program, I would like to introduce, and I would like to say first that in this today's presentation, we have a representation from almost all part of the country. We covered most of the part of the country of premium institutes, high volume centers, where I know they are emirators or they are pioneer in the management of anaplastic thyroid cancers. If we talk about from South, we have Dr. Arvindan Nair sir. Dr. Arvindan Nair sir is the former HOD Department of Surgery, CMC Vellore. Those who are endocrine surgeons, he doesn't need any introduction. Still, he was the founder of Department of Endocrine Surgery, and MCH in endocrine surgery was started under his leadership. And he is the mentor of all mentors, all senior mentors who are working in India, in abroad. They are being mentored by Dr. Arvindan Nair sir, and he is in the process of joining us. He's the Emeritus of Professor Surgery, MGR Medical University, and right now, after his retirement from CMC Vellore, he is working in Navuri Hospital in the same city. Now we have Dr. Punita Lal ma'am. Dr. Punita Lal ma'am is the professor and head and a very strong pillar of Department of Radiation Oncology from Sanjay Gandhi Postgraduate Institute of Medical Sciences, one of its name in whole world, especially in management of high-profile cases, high-end cases. And she was one of my mentors, and I learned from him and I still learn from her. I still learn from her. Thank you, ma'am, for joining us.
Thank you. Thank you.
And I am looking forward to learn so many things from you today. And we have with us Dr. Divya Dahiya ma'am. Dr. Divya Dahiya ma'am is the professor in Department of General Surgery at Chandigarh PGI. And she's one of the pioneer. And right now she's in charge of breast and endocrine unit. So she is really working hard to get recognition of breast and endocrine surgery at her place, and she is succeeding quite a lot, and she's truly inspirational. I learn a lot from her. Thank you very much for joining us, ma'am, today. And she's from Chandigarh PGI, and we know these are the very high volume centers, anaplastic thyroid, and they cater the anaplastic thyroid centers in their centers because they are very high volume centers, right? We have Dr. Sabha Ratnam. Dr. Sabha Ratnam is one of my dear friends. He is a professor of Department of Breast and Endocrine Surgery at Sanjay Gandhi Postgraduate Institute of Medical Sciences. A very, very skilled surgeon I have ever seen in my life. And he will be joining us shortly. And we have Dr. Chani. Dr. Chani is a senior oncopathologist, and we work together. We solve so many oncological riddles together. An important thing, we keep a record of each and everything. Even in our small setups, we try to provide the best quality care to our patients, and nonetheless, we are active in our academics so that we can update ourselves on a regular basis. Thank you very much, Chani, for joining us. And important, and the most important one is Dr. Amish Vora. So Dr. Amish Vora, I'm so delighted that he's with us today. If I introduce him, he is one of the senior medical oncologists. He did his training from All India Institute of Medical Sciences, and he was associated with Tata Memorial Hospital. He did his part of his training from NHS Cardiff Hospital, Wales, and he was an observer from MSK CC New York and UCSF San Francisco. And right now he's a director of Hope Oncology Clinic. So many awards and accolades in his name. And while I was working with him, on this case, I was truly impressed with the intellect that he has. And yesterday also I said, sir, I'm really looking forward to learn so many things from you. And today is the day. So without wasting much time, I now start my case. So now I'm sharing the screen. I think Arvind sir has joined. So may I request Arvind sir if you can, without his introduction, so I cannot start. If he has joined, and I'm so glad Amit sir has also joined. So I would like to introduce one of our guest faculty is a medical oncologist, Dr. Amit Upadhyay sir. Sir, may I request if you can open your camera?
Am I visible, ma'am? I think.
Nah, you are visible, sir. I think the audio visual is okay.
Yes.
Right. So Dr. Amit Upadhyay sir is a very senior medical oncologist from New Delhi. So he's associated with PSRI hospital, which caters most of the cancer related patients. And I am associated with sir, and I usually work together for the breast cancer patients and other cancer patients. And I have never met such a humble personality with such an high intellect. Thank you very much, sir, for joining us. And I am sure with the multidisciplinary team of medical oncologists, radiation oncologists, surgical oncologists, endocrine surgeons, We are going to learn a lot, and I think Dr. Vishwak has also joined. Dr. Vishwak is the chief and head of Department of Breast and Endocrine Surgery at Rajiv Gandhi Cancer Institute. So he's an alumni from Sanjay Gandhi Postgraduate Institute of Medical Sciences. And Rajiv Gandhi Cancer Institute, as such, we can understand, is a very high volume cancer research and treatment center. So I'm looking forward more insights from him as well. And he may be traveling, but he will be joining us in between also, and probably we would be getting insights from him. So Arvindan sir has joined us. So may I request Arvind sir if you can also open your camera. And I'll just check if he has joined. Thank you, Vishwak, for joining. Okay, so now my screen is shared.
Thank you.
Thank you, Vishwak. Yeah, so now I'm sharing my screen. And I hope it is visible. I hope it's visible, right? So now if I start about this anaplastic thyroid cancer, those who are here, they already have very sound idea about what is a thyroid cancer and what is anaplastic thyroid cancer. This is my team of speakers today, and this is my team of guest faculties. Already I have introduced each and everyone to you. So now if I present this case, I would, for the case presentation, I request Dr. Amish, because he was the primary physician who managed this case to tell about, like, sir, you please
Thank
start.
you. Thank you, Dr. Kamboj. And in a presence of such dignitaries, I never thought that I will have this good fortune. And before I start, I wanted to congratulate Dr. Kamboj. The enthusiasm which he alluded in last few days, I can't tell. I cannot imagine somebody so dedicated to this program. And I thank my colleague Dr. Amit Upadhyay, because he was also one who introduced to me to Dr. Kamboj, and such wonderful job you are doing in breast and endocrine surgeries. Ma'am, congratulations. Keep up this type of enthusiasm. India needs more people like you for us to learn more and more things every time. And I also thank my another dear friend, Dr. Sushant Rohila. As Dr. Kamboj said, that he's a dentist, prolifing practice in Australia. And this patient is his relative. And I think he's also the one who kept sharing with me the articles in this difficult case. So I'm a medical oncologist, and we treat all types of cancers, not specifically thyroid. But this was something interesting, and we thought that we will learn from each other. With that, I start my case. I say 70-year-old female, hypertensive, non-diabetic, no CKD, no major surgery in the past. There is no family history of cancer. She complained that pain and swelling on the left side of the neck since 2 to 3 months. Although when you ask her, she said, 5-6 महीने से थोड़ा तकलीफ तो था मुझे. The slowly swelling increased over 3 months. Now, everybody who sees thyroid cancer, differentiated and de-differentiated, they would know that in differentiated thyroid cancer, 3 महीने में इतना जल्दी symptoms नहीं बढ़ते हैं. So that was something which was little red flag here. Dysphagia also started along with the same time. She specifically said that while lying down straight, in fact, while sleeping in the night, some tightness in the throat and tightness in the chest. She had a weight loss of significant weight loss in over 4 months. On examination, there was a hard fixed supratracheal mass, which was palpable. Next slide, please. So this was actually the mass palpable. The surgeons would know it better. Dr. Sudhi, do you, sorry, I know you are supposed to come later, but can I ask you that on palpation, do you get any idea between differentiated and de-differentiated thyroid masses?
Yeah, most of the time, like as soon as we touch the neck, we get to know this is operable or this is not operable, or this is a challenging case, or this is like a butter on a knife on a butter, like something like this case. So this case looks like this is not looking like a very good case to me. I haven't touched, but most of the cases we understand that this is not going to be a easy case for me.
So, Dr. Kamboj, when not a good case, that is the time when medical oncologists enter, and we try to make it a good case. Let's see whether we were
Yeah.
able to do that or not. So, ultrasound neck classical left-sided thyroid mass was seen, as we will do in any other case. Patient was asked to do FNAC from this thyroid mass. Next slide, please. So FNAC surprisingly showed that it is positive for malignant cells. In fact, the smear was done from thyroid and from the lymph node both. And both were positive for malignant cells, and the lymph node FNAC showed metastatic squamous cell carcinoma. Now, because it was metastatic squamous cell carcinoma, the review was done in another lab, and another lab also said the same thing, that left lobe of thyroid has carcinoma with squamous differentiation. Now, this was something which, when at this time the report was sent to me by Dr. Sushant, and I was a little surprised. I said, because he asked me about a good thyroid surgeon in the city of Delhi. I said, report bhejo, and this report said that something is different. Next slide, please. So we were little perplexed here that either this is a de novo squamous cell carcinoma from the thyroid, or it is a metastasis from some other primary in the body. Like, I have seen lung cancer going to the thyroid. I have seen in females breast cancer going to the thyroid. And I have seen a separate thyroid malignancy also. That is something what we call as an incidentaloma. And we have seen so many incidentalomas in this. But this particular patient had cancer in the thyroid, and that was squamous cell cancer. So we thought that let us do the PET CT before we do the biopsy, because if there is primary anywhere else in the body, then we'll have to plan the biopsy in that particular way. Next slide, please. And here, can I request Dr. Sudhi to take us over? Medical oncologists are very poor in radiology. Our anatomy is very pathetic. So please explain to us.
So I will not go into much detail, very clinically significant points that I'll be telling. This was a non-contrast CT scan. Most probably patient's creatinine might not be into that, might have raised. That is why it was being done. So the contrast is not good. What we can see that there is a multinodular goiter, more on the left side, and which was displacing the trachea towards the right side. And if you can see, this mass is going retrotracheally, and the plane with the trachea and the esophagus was not delineated. We cannot differentiate the plane between the trachea and the esophagus with the thyroid mass. The mass looks smudgy, and the planes with the sternocleidomastoids and the uh, strap muscles was also not very well maintained. That what we see in usually benign cases. There were lymph nodes also in the level 4 and level 5. So this all we can see. If we see in this coronal section, so there is a multinodular goiter, and this left side is displacing the trachea towards the right side, and this mass is extending retroexternally. So there is a significant retroexternal extension, though not much, but it was significant. Yeah. And the lymph nodes are also there. You can see the lymph nodes are there on both the sides. So the most appropriate CT scan in such type of case is usually contrast enhanced CT scan, but unfortunately only a non-contrast CT scan was being done. Limited information can be gathered through this CT scan. Now, this is about PET scan. That was because she was a malignant case, and as already sir said, it could be a metastatic disease also. A PET scan was done in October 2025, which showed a metabolically active, large soft tissue density mass lesion, inferior aspect of the left lobe of thyroid, partially compressing and displacing the trachea, extending to tracheoesophageal groove with indistinct planes with adjacent esophagus, could be neoplastic. And also she has a metabolically active cervical lymph nodes which are metastatic. Otherwise, in any other part of the body, there was no evidence of metabolically active disease. And this is the scout film, we could say. And you can see The disease is not looking good, and there's a lot of metastatic lesions in the left cervical area, and the left thyroid lobe is definitely, it is neoplastic. Just have this picture in mind, because later on when we'll show you the post therapy results, then we can compare these two pictures. So the core biopsy was done. Sir will tell about this, and then
Yes.
Dr. Chatti will elaborate. Yeah.
I think Dr. Chani also can add here. My role will start coming when the NGS is there. So if the Dr. Chani is going to present later, I would just say that the biopsy from the thyroid mass confirmed that it was a primary squamous cell carcinoma. Although if Dr. Chani is here, one thing which in the third line in the microscopic, they have written no thyroid parenchyma is seen. Dr. Chani, if the primary thyroid malignancy is suspected, some amount of thyroid parenchyma and some amount of differentiated cells like papillary differentiation is seen, or this is standard squamous cell. Dr. Chani, you can come here. I think Dr. Chani probably is unmuting. So by the time she comes, the immunohistochemistry was done, and immunohistochemistry showed few important things. One is P53 was mutant. Second, Ki67 was 80%. So P53 we all know, is a tumor suppressor gene, and what we read in MBBS was a gatekeeping gene. P53 mutant means that it is a very aggressive form. Ki67 80% is also shows higher the Ki67, more is the aggression. So just to give an example, in a breast cancer, Dr. Kamboj would say that the Ki67 can range from anywhere from 10% to 30% to 40%. In lymphomas, especially in Burkitt's lymphoma, Ki67 can be 90 to 100%, what our colleague Dr. Amit Upadhyay would agree. So this was a highly aggressive, rapidly multiplying type of tumor, which core biopsy shows. Next slide, please. So far, what we had was there was a large thyroid mass causing compressive symptoms, rapidly increasing these symptoms. There was cervical lymph node, especially supraclav lymph node also was there, and the biopsy showed squamous cell carcinoma. Now, patient was referred to an oncosurgeon, and Dr. Kamboj, you would agree that this patient at this point of time with the PET CT was inoperable, right?
Yeah, definitely, sir. It was an inoperable disease, a nightmare for the surgeon at least.
Fine. So at this point of time, the family member, especially Dr. Sushant, came to me and said, "Sir, if the surgery is not possible, what is the prognosis?" Everyone who is looking after anaplastic thyroid carcinoma, they know that squamous cell carcinoma is initially was a type of anaplastic, but now it is sort of a separate. Although you say anaplastic with squamous differentiation, but squamous cell carcinoma, primary from thyroid, is even less than 1% of the thyroid malignancy what we see. And the next slide, please. So we sat down with Dr. Sushant, and we said that if the patient cannot be operated upon, the median survival was less than 9 months. And when I told this, that the next year will be a difficult thing, for your relative, it was actually a nightmare for me also to tell such things. But we have to be honest and explain. So we explained that the median survival, or this particular patient survival, is probably less than a year. Next slide, please. We immediately started treatment because I was worried that she should not land up having tracheostomy, or she should not land up having complete dysphagia. So we started with nab-paclitaxel and carboplatin. I searched through the literature. In an anaplastic carcinoma, normally we give etoposide and cisplatin, or etoposide and carboplatin, but there were many case reports of taxane plus carboplatin. So we started this on weekly basis, slowly, darte. Meantime, the biopsy sample was sent for next generation sequencing, that is the mutation studies, and PDL1 by immunohistochemistry. Patient started responding from second week onward. She's saying that, okay, my chest is little lighter, I'm little better. Although the dysphagia still persisted, I was constantly keeping my toes and my fingers crossed that We should not land up having tracheostomy. Luckily, patient responded quite well. And before the third week of chemotherapy, we also got NGS report. Next slide, please. And this NGS report showed us three things. One, it was a BRAF V600E positive. And the VAF, that is the variant allele frequency, was 9.46%, which is significant. And second thing was TERT. Now, this is significance, which I'll explain in the next slide. Next slide, please. And the PDL1 CPS score was 100%. Every BRAF V600E mutation in thyroid is not like a terminal case. 50% of papillary thyroid cancer will carry BRAF V600E mutation. So it is said and it is believed that this is the beginning of the carcinogenesis where the BRAF V600E mutation comes up. And as the dedifferentiation increases, as the aggressiveness of the tumor increases, the TERT mutation is seen. So if you see BRAF V600E, does not mean it is a bad prognosis. But if you see the TERT mutation along with that, or TP53 mutation along with that, with Ki67 of 70%, 80%, and we saw that P53 and IHC was mutant. So this particular patient's cancer had started from BRAF V600E, had gone towards the highly aggressive, and that's where the TERT mutation and P53 mutation also was there. So this means that this was a very, very aggressive thyroid cancer based on biopsy, IHC, and NGS report. But silver lining in the dark cloud, I would say silver lining in the dark cloud because it gave us some this. PDL1 was 100% positive. Just people who are not familiar with PDL1 concept, PDL1 is a stain. It's a marker for using immunotherapy. It's not a complete marker, but it is a marker what we have right now. Anybody who has PDL1 of 1% can qualify to receive immunotherapy, and here it was 100%. 100% PDL1 we rarely see. We see one or two cases in a year of PDL1. Otherwise, it is 1%, 5%, 10%, rarely 50%, but 100% is very, very. So I was quite elated when I saw PDL1 100%. Next slide, please. So at this point of time, patient had responded very well to chemotherapy. So I was in a fix. I said, should I shift to BRAF V600E mutation, this thing? Should I continue chemotherapy? Should I add immunotherapy? I decided that I do not want to lose a winning combination. Patient was responding quite well to chemotherapy. So I added immunotherapy here. So the point is, why am I saying this? So assuming if we had all this information before we started chemotherapy, would we have treated this patient differently? And that is where next 2-3 slides I would like to share. Next slide, please. So first thing in any treatment, in any anaplastic thyroid cancer, even though I'm a medical oncologist, but I don't have any shame in saying surgeons, surgeons, and surgeons. It is the resection which extends the survival. We are desperate in this dedifferentiated thyroid cancer. Somehow, kahin se bhi hote hue surgery ho jaye. But if unfortunately patient is unresectable, then we have various drugs. Earlier, we used to give chemotherapy, radiotherapy, then slowly the targeted therapy came, then the immunotherapy came, and then our concept of NGS started developing, evolving. And as a result, we have little bit better than what we were 10 years back. Next slide, please. Dr. Kamboj, can I have the next slide?
Sure.
Yeah. So the BRAF in this red, if you see the circle, that is where the carcinogenesis has started. So scientists developed the drug against the BRAF. But what they found out is was very short-lived response. So they said that why it is short-lived. So they said, okay, from BRAF it is goes to MEK, MEK to ERK2, and then the tumor initiation and the tumor progression starts. So can we give a dual blockade, which is BRAF MEK inhibitor combination, what we call as. Next slide, please. So this combination, famously what we use in lung, melanoma, colon and thyroid cancer, is a combination of dabrafenib and trametinib. Now both are oral drugs. Both come in the group of tyrosine kinase inhibitor. So if you see on your left hand side and my left hand side of the slide, is a what we say a waterfall plot chart. So anybody who is above the x-axis are the patient who did not respond to this combination. And all other vertical bars on below the x-axis are all the patients who have responded to this particular combination. So as you can see, so many patients respond to this particular combination. When we were talking of chemotherapy, we would say majority of the patient would respond to chemotherapy, but they would progress very fast. So here we said two combination of oral drugs, and this is what the beautiful response was. And the median OS for the first time in anaplastic thyroid cancer crossed 1 year, which we didn't think that we will see that. Next slide, please. 1/3 of the patient in that combination lived beyond 2 years. The only disadvantage, like chemotherapy, the tumor resistance developed very fast with these tablets. The cancer is very smart, it developed. So some nice person, some good scientist and a good medical oncologist, they studied and they showed that if you add immunotherapy drugs and if you increase the immune survivorment or the microenvironment in a way that the resistance pattern is taken care of, then in that case can it be better? So the DT, dabratremi, then it called DTP, Dabra, Tremi, and pembrolizumab. Pembrolizumab is an immunotherapy. And the survival changed. It became longer, as you can see, that this particular combination, and this was in thyroid cancer 2024. This was published that if the DT alone gave 9 months of median OS, in this particular study, the DTP almost doubled the overall survival. So adding immunotherapy drug, it added that. Next slide, please. The most important thing is, as I always said, that surgery, and surgery is the reason for a person to live longer. So if you take this DTP as a new adjuvant approach, and I must say here and must give credit to Dr. Sushant, because Dr. Sushant, first time he must be reading through everything and he sent me this particular slide. He said, sir, kya DTP hum use kar sakte hai? And I said, yes, of course. And that is what we're discussing. So if we use DTP in a neoadjuvant approach, followed by surgery, followed by radiotherapy, followed by DT, then the patient from 17 months, the median OS was 63 months, 5 years. Again, in my career, when I was in AIMS, I was doing my DM. I never thought in my lifetime, anaplastic thyroid cancer, I will ever hear this word of 63 months. Next slide, please. So, in this particular patient, we continued chemo plus IO because, as I said, we did not want to change the winning combination. But keeping in the mind that we have dabratremi and we have the neoadjuvant approach of that. After 9 weeks of chemo and 4 doses of immunotherapy, we evaluated again. Next slide, please. And this follow-up CT, there was a very good... Yes, Dr. Sudhi, can you take this?
Sir, you can continue.
Okay, perfect. When the PET CT comes, you can probably explain to us. So there was reduction in the size, extent, FDG active left lobe of thyroid, reduction in the left cervical lymph nodes. Again, I was very happy. I said, अब तो surgeon operate कर ही देगा यार, मतलब कुछ भी करके करना पड़ेगा करके. Next slide. So, Dr. Sudhi, you can take over here. And you don't have to say no to any medical oncologist like that. ऐसा नहीं बोल सकते हो कि operate नहीं हो सकता. कैसे भी करके करना पड़ता है.
Yeah, definitely. But like we certainly have to wait. If we can get more operability, then less post-operative morbidity will certainly be there. So, but I'm truly amazed with the response that I could see, and I'm now sharing this with you all. So this is the CT scan done in December after the therapy, and you can see now. If I show you this slide, this is a comparative slide. So this is the pre-treatment CT scan, and now you compare this with the post-treatment CT scan, and you can see the result, the significant response that the patient has achieved within the 2-3 months of the therapy. And if we see this colored image, so this is the uptake that was there, and this is the uptake in the lower part of the left lobe of the thyroid, and these are the cervical lymph nodes showing the uptake, and this is the post therapy response in the tumor. The uptake has drastically reduced, and not only the uptake, the size of the lesion has also decreased a lot. Since I haven't seen the patient, so I cannot comment, but most probably, but still I think there could be further possibility if the lesion can be reduced further with any efforts. So Dr. Amish can tell about this further
So
here.
the next slide, please.
These
And the
are
next slide.
the cross section.
The cervical lymph nodes had completely FDG had gone. So I was very happy, but surgeon like Dr. Kamboj told me that, Dr. Vora, please do something more. And we would like to operate her at the optimum time. Again, I blindly follow my surgical oncologist advice because they know their subject better than us. So we said, fair enough. Now is the time to introduce Mark Zephyro protocol, and this particular, and I'm sure Dr. Kamboj in next few next slides also she will be speaking. So this Mark Zephyro protocol is a triplet of dabrafenib, trametinib, and pembrolizumab. And what we had decided, because this patient already was on pembrolizumab, we said that every 6 weeks we will do the imaging, and whenever the patient is suitable, we will go for surgery. Can I have the next slide, please? So this was the Mark Zephyro protocol. And this slide, thank you, Dr. Kamboj had provided me. I was trying to search, I couldn't find this slide, and thank you. In fact, she has provided many other slides in the skeleton of the PowerPoint presentation. Thank you for that. So what this says is that you start with 2 oral tablets. You run into oral tablets for 21 days. Now, why this is important? We say 2 oral tablet. Dabra and Tremi are not a very easy drug. Sometimes tremetinib gives rise to a lot of weakness, gives rise to a lot of fever. In fact, pyrexia is one of the major side effects, and you should know how to give paracetamol, what to do. I have one of my patient of Dabra Tremi responded extremely well. PET scan absolutely normal, but that patient has such bad myopathy. Last 3 months, patient is not able to get up from the bed. So, these are not easy drugs. And that's why it was decided that you do a run-in of 21 days and then add pembrolizumab every 21 days after that. And you look at surgery after 3 cycles of DTP like this. After surgery, if you have you start give radiation, if the radiation is visible, that is IMRT was given in this particular this thing, and you complete 6 weeks of RT with pembrolizumab. You do not stop pembrolizumab. After that, if the patient is able to tolerate, continue DTP or continue on the observation phase. And based on this protocol, I had shown you the median OS crossed 5 years, and 1/3 of the patients were alive at the end of 36 months. Also 36% not progressing at the end of 3 years. Again, it's like a miracle what happens. Next slide, please. Yeah. So now from here, I hand over to Dr. Kamboj. Thank you so much for giving me this opportunity.
Thank you, sir. It was really very informative and insightful. So, why we chose this case for discussion today? First of all, as already said, though this case was not primarily managed by me or my team, but since we came across this case and we noticed that so many new investigations are being done and so many new therapies are being given to this patient, and which is showing such a good response, it naturally craved us to discuss about this. So through this program, we would like to understand what are the pre-operative works of most of which sir has already discussed. What are the various treatment strategies, especially the medical, is for those unresectable tumors? What is this Mark-Jaffe-Rio? What are the surgical criteria? When should we assess that now this patient is ready for the surgery? What are the follow-up data, and what are the pathological and management differences between anaplastic thyroid cancer and squamous cell carcinoma of the thyroid? Because the very first time when I received the report of squamous cell carcinoma in thyroid, my first impression was it could be a metastatic disease. Either the report is wrong or it could be a metastatic disease of the thyroid. But when on multiple locations we received the same report, especially in the core biopsy also, when we received the report of squamous cell carcinoma, my curiosity aroused, now what next? And through this program, we would like to understand that this patient is responding in the line of anaplastic or squamous cell carcinoma. With the help of expert, we would like to understand how the management would have differed in such case. So overall, we would like to understand what are the recent advances in the management of anaplastic thyroid cancer. Very brief about what is anaplastic thyroid cancer. We all know these are very, very aggressive cancer. They account for 5 to 10%. And they are very lethal form of thyroid cancer. And usually they present with distant metastasis at the time of presentation. It is around 30 to 40%. And majority of them are unresectable when they first present to either to ENT surgeon, endocrine surgeon, or any other oncosurgeon. The pathogenesis, most of the studies, they say the environmental and risk factors, especially long-standing goiter or multinodular goiter, any prior history of thyroid cancer, radiation exposure, older age, female predominant, multiple things. In this case, as sir has mentioned, I think BRAF mutation was the initiating one, and possibly she might be having some papillary thyroid cancer, which later on, uh, due to further mutations, transformed into the anaplastic thyroid cancer. I'm not sure about this thing. This is just my prediction. And cellular mechanism is there where there is a de-differentiation in an already known case of papillary thyroid cancer. We know they de-differentiated, known as poorly differentiated or de-differentiated thyroid cancer. And usually these tumors, they exhibit pleomorphism, necrosis, and high mitotic index. Sometimes these are de novo thyroid cancers. They arise directly from the previously normal thyroid. Due to some mutations, some either genetic factor is there or due to some external factors, especially the radiation exposure, where the TP53 mutation, BRAF V600E mutation, RAS mutation, TERT mutation. Already sir has shown us the slides. And these are the various mutation which leads to aggressive form of tumor proliferation and tumor progression. So this is a slide. I think Dr. Chani can explain a bit about how this mutation actually happens. And Dr. Chani, would you like to tell something about this slide? It's just a brief outline, and I think sir has already told about there. Basically, this is a vascular and this is a growth factor receptor, and through various. Yes, Chani. You are muted, Chani.
She's unmuted. Okay.
You're not audible. No, you're not still, you're not audible. I think there is some technical issue. So, so this is the BRAF leads to MEK. I will not go into the detail because sir has already told, but why this slide is important, because now it is the time of the molecular level therapeutic agents that we are giving. These are targeted agents, usually tyrosine kinase inhibitors, and these have a very, very promising result. The one just we have seen now. So, this is the histological features of this is for because many of the postgraduate students are also with us. They are the trainees or the senior residents in the Department of Breast and Endocrine Surgery somewhere in India. So it is for the sake of their interest. We are presenting these slides.
No.
No. So I think Dr. Chani is finding some difficulty. So I explain these slides to you all. So this anaplastic thyroid cancer, usually if we see in gross, they are large ill-defined infiltrative masses, fleshy variegated surface hota hai inka, and on microscopic, usually they have pleomorphic cells, they have multiple shapes and sizes. There's no fixed shape or size. There's a necrosis, mitosis. They are infiltrating usually adjacent structures. So extracapsular extension is there, and they could have multiple epithelioid, sarcomatoid. And I think I will do injustice if I explain this. Let them be explained by Dr. Chani. So she will explain once she will have once her technical problem is resolved. What I will be telling you as an oncosurgeon, as an endocrine surgeon, the challenges that we usually face with anaplastic thyroid cancer, right? So important is these cancers are really difficult to manage because they have a very, very rapid progression. Your tumor doubles in size within few days or weeks, and they often presents with local invasion like trachea, esophagus, or they have maybe IJV invasion or distant metastasis, lung, bones. So these are very difficult to manage. Mostly patient present with these symptoms only. They frequently are diagnosed in either stage 4 or stage 3, where they have local infiltration, and they may be having symptoms of neck mass, dysphagia, dyspnea, horses. The dysphagia that is was there in our case. And most of the cases are inoperable when they first present to us. They have a very poor prognosis, median survival of 3 to 6 months, and 1 year, hardly they see 1 year once they are diagnosed. And most death result from airway obstruction or metastatic spread. So that's why sir was talking about the tracheostomy. We have very limited treatment option because these tumors are not, majority they are not responding. Surgery, most of the time we are not able to operate. They are radioactive iodine refractory because they are de-differentiated or poorly differentiated. Radiotherapy, it gives some palliative control, but tumor is usually radio resistant. And I think Punita ma'am will throw more light on this aspect. Chemotherapy, it has some modest response, but usually patient have a very high side effects, and usually the disease recurs once the chemotherapy is stopped. Then usually the disease recurs, and it has a partial response only. Targeted therapy has a limited success. Sir has already told about dabrafenib and trametinib, and the response, the resistance that usually develops if only 2 combination is given. And immunotherapy, it is being explored. It is a very new, since anaplastic thyroid cancer as such is very rare, and giving them treatment with immunotherapy. So there are a lot of data that apparently looks promising to us. Hopefully, we really have a very good control with this immunotherapy. And multidisciplinary complexity is there because it requires a lot of collaboration with endocrine surgeon, oncologist, radiation therapist, pathologist, and palliative care team. So airway management is very, very important. So if it really the airway is compromised, then we have to sort for tracheostomy or stenting, and often it becomes urgent and complex. So now if we talk about the management, suppose a patient comes to me for a thyroid problem, I first like to assess whether the patient is operable or inoperable. And suppose we are not talking about the operability right now. We are just focusing on inoperable patients with anaplastic thyroid cancer. Then what next? Everything we have already discussed, and now sir will elaborate and will give a mind map now what to do with such patients if the patient is inoperable and outside the domain of a endocrine surgeon, thyroid surgeon.
Yeah. So I think the mind map, which Dr. Kamboj told me to tell, right now we are talking of BRAF mutation because I think, non-BRAF mutation also, as Dr. Kamboj showed the first slide, which was supposed to be, shown by Dr. Chani. There are so many targets and so many drugs are available. If I start narrating all that today, I don't think I'll be able to give a clear message. So let's talk of BRAF. Very simple thing. If patient can be operated upon, as Dr. Kamboj said in the previous slide, surgery, surgery, and surgery. If the patient is not operable and patient has BRAF and no brain metastasis, you give new adjuvant. DTP has become the standard treatment. Dabrafenib, trametinib, and pembrolizumab. Although it was a phase 2 study, there is no phase 3 randomized trial available for this, but this is the best what we have. And the second best is not that good. So that's why many a times we change our practice based on phase 2 data. And after 3 months of DTP regimen, you again check whether patient is resectable. If the patient is resectable, go ahead and do surgery. And after surgery, you give radiotherapy and continue with DTP if the patient is fit. If the patient at the end of 3 months is found to be unresectable, then you continue DTP for another 2-3 months, again reassess. If at two different time points, if the patient has found to be unresectable, in that particular point, you see if the patient can receive radiotherapy or not. If the answer is yes, give radiotherapy to the patient, because as Dr. Kamboj mentioned, even though it is palliative, it will have some effect on the extension of the survival, and it may prevent the tracheostomy requirement for a long time not to come. If the patient is not a candidate for radiotherapy, then you continue DTP. And once the patient progresses on DTP, then you continue other targets or the chemotherapy. And that's how you increase the survival for 1.5 to 2 years to 2.5 years. Remember, if you can't operate, the survival even today with best of the thing is 2.5 years. And if you can operate, then the survival goes beyond 5 years. So you, as Dr. Kamboj mentioned, multidisciplinary. Please do not forget your oncosurgeon at any point of time. Keep hammering them and say whether patient can patient can be resected or not. And it is stage 4C. Almost it remains the similar, except for you have to see whether brain mets. And normally we do one MRI of the brain to see whether patient has brain metastasis there or not. If the brain metastasis is present, then you have to give first radiotherapy to the brain or a very close observation, and then start like you would start for stage 4B. Rest remains the same. Some other point of time we will talk of non-BRAF, but I think that would be too much of the thing to be palette, and I would say this is where is a mind map. We should stop here. Dr. Kamboj.
Yes, sir. So, like, if I summarize, this suppose a patient comes with an inoperable thyroid cancer. We first do a core biopsy to confirm our diagnosis, like whether it is non-Hodgkin's lymphoma or anaplastic. Suppose it comes out to be anaplastic thyroid cancer. What ISC would you suggest in such cases? What further investigation? The histopathology say कि it looks like an anaplastic thyroid cancer. What specific investigation then you ask for?
Right. So as I mentioned, we normally follow the guidelines. And the guidelines say that whenever there is something unusual, like for example, in this particular case, please confirm with biopsy and immunohistochemistry. Now in IHC, normally, if you by any chance, if you find thyroglobulin stain positive or TTF1 positive, and your scan says that there is nothing in the lung, then the primer in the thyroid is confirmed. But before that, you would look at your histopathology slides by your histopathologist, and somewhere, anywhere, if they can see some papillary pattern, again, you know that primary probably is the thyroid, right? So these are the things. So FNAC, malignancy confirmed, biopsy followed by PET or PET followed by biopsy. See if the disease is spread anywhere else or not. If the disease is not spread anywhere else, multidisciplinary team approach, mandatory, absolutely mandatory MDT. Oncosurgeon, how comfortable in resecting or not. If unresectable, then I have narrated here. But BRAF V600E can be done on 3 different aspects: immunohistochemistry, RT-PCR, and next generation sequencing. IHC shows a protein expression. RT-PCR gives a specific particular type of mutation, is a hotspot mutation because it amplifies. And NGS will capture depending on RNA, DNA, whatever you are doing. RNA is always better because sometimes the fusions are missed on only on DNA. So RNA studies of NGS, and that will tell us that whether patient has BRAF V600E mutation, although that can be picked up on DNA NGS also. This is extremely important because you cannot miss the presence of BRAF V600E in anaplastic thyroid cancer. It will be a crime if we miss that, because we have so specific treatment now available. I hope that
Right.
answers your question, Dr. Kamboj.
Right, sir. Right. Thank you very much. And we'll be asking you more about after we finish with this presentation. And I think Chani, Dr. Chani is there. Is the audio problem solved?
Am I audible now, ma'am?
Yeah, thank you very much, Shani. So I just go through your slides which were missed. So may you please throw some light on what are the anaplastic thyroid cancer and the various histopathologies which you as an histopathologist would like to recommend in any case with anaplastic thyroid cancer on core biopsy, and what are the various differentials and how do we differentiate? Yeah.
Okay, thank you, ma'am. So just a brief description on gross examination. Anaplastic carcinomas are usually large, ill-defined and infiltrative masses, and cut surface is fleshy and variegated with areas of hemorrhage and necrosis, as we can see in this photograph. And in microscopy, as the name suggests, it is anaplastic, so it will show pleomorphism, necrosis, lot of mitosis. It will be infiltrating adjacent structures. Now, anaplastic shows a lot of variety of patterns, like epithelioid pattern, sarcomatoid pattern, zygomorphic. And the rare ones include the SCC pattern, which we are seeing in this case, then angiomatoid, paucicellular, rhabdoid, lymphoepithelioma like. Next slide, ma'am. So immunohistochemistry plays a very important role in diagnosis of anaplastic, especially on core biopsies. So positive markers which are helpful are PAX8, one of the most useful markers, then cytokeratin, P53, BRAF VE1 antibody for BRAF mutation can be used. K67 index is high, usually more than 50%. EMA and Vimentin are positive but not very specific markers. In SCC pattern, we'll find CK5, 6, P63, which was put in this case also, P40, 34 beta, E12, P53, and PAX8. Can be positive in minority of cases. In CD45, which is a marker for lymphoma, calcitonin, chromogranin, synaptophysin for parafollicular cell origin, all these will be negative. Then S100, HMB45 melanine to differentiate from melanoma, all these markers will be negative. Next slide, ma'am. So as it is a variety of histological patterns, so the differential is quite long. So I have tried to make it as brief as possible. Early it will show less pleomorphism and TTF1 and thyroglobulin will be positive. Squamous cell carcinoma of head and neck is a very important DD if we are getting a squamous cell pattern. So important marker for this is PAX8, which is a thyroid origin SCC. Other differential tumors, sometimes they show squamous differentiation, but there will be absence of necrosis and mitosis. Then medullary will show the usual markers. All the different entities, non-Hodgkin's, metastatic carcinoma, angiosarcoma, pleomorphic sarcoma, metastatic melanoma, all of these have their own markers also. And an important feature to notice, PAX8 is helpful in differentiating a lot of these entities from a primary SCC of thyroid. And then radial thyroiditis, it is a DT for the paucicellular variant of anaplastic, present in a similar way. But in radials, there will be no atypical. Next. This is just to give an overview of the histological findings. So first micrograph is of a normal thyroid. And next is of a follicular thyroid carcinoma where the nuclei are round with variably cold. Then third photomicrograph is of a papillary thyroid carcinoma, overlapping and clearing is also seen. Then third is of a medullary thyroid carcinoma, where with this pinkish material, lot of amyloid deposit is there, and in between nests of tumor cells are there. Now, if we compare anaplastic from all of the above four, we can see marked pleomorphism and areas of necrosis in the anaplastic thyroid carcinoma. This is an last one is a keratinization. All this pink material is the keratinization we are seeing in the squamous cells. That's it.
So now, one very important point, because this patient has a squamous cell carcinoma diagnosed in her core biopsies. So there are two important slides that we have put. First of all, how to diagnose between this squamous cell carcinoma of thyroid and ATC, for which Dr. Chani will help us. Can you please explain this slide?
Earlier, squamous cell carcinoma of thyroid was a separate entity, and we used to define it when the tumor was purely comprising of squamous cell carcinoma with no differentiated component of any type of thyroid carcinoma. But in the 5th edition of WHO classification of tumors, 2022, they have included this entity as a subtype of anaplastic carcinoma. Reason being, they have a similar clinical presentation, similar disease progression, and at molecular level also, since anaplastic thyroid carcinoma showed positivity for BRAF and PAX8 and in some cases even TTF1. So considering all the features, they have included anaplastic SCC of thyroid and anaplastic carcinoma only. So what in such a scenario, mainly if we find such a picture, we have to differentiate from metastasis or direct invasion of SCC from oropharynx, larynx, trachea, lung, and other organs. Papillary carcinoma, in around 30 to 40%, 15 to 30% cases, it can also show foci of squamous differentiation. Then anaplastic thyroid carcinoma with squamous differentiation, and other thyroid carcinomas with squamous differentiation like the mucoepidermoid carcinoma, sclerosing mucoepidermoid carcinoma, etc.
Yeah. So now, Dr. Amish, I would request if you can give us some take-home message. And before that, if you can put some light on, is there any management differences between squamous cell carcinoma of thyroid, unresectable, and the anaplastic thyroid cancer? So is there any management difference, or the management is almost same in both the cases?
Management is almost the same, and all these take-home messages we have discussed. So I think everybody, 2-3 times I have spoken about this. So Dr. Kamboj, maybe now you can involve the faculty in this. I am also keen to hear from them.
Yeah, thank you very much. And with this, now we have finished with our presentation, and the forum is now open. I'm stopping my screen share so that I can see all of you. And yeah, stop share. So yeah, stop share. Yeah. Fine. So thank you very much. Now the forum is open for discussion, and for the discussion, we have very eminent faculties with us. First of all, I would like to welcome Dr. Arvindan Nair, sir. Due to some technical error, sir was not able to join early. I think sir is there. Yes, sir. Sir, welcome to our forum, sir, and it's our pleasure and honor to have you with us today.
Thank you. Thank you
Sir is
for
the mentor of all mentors, those who are working in India and abroad in various high-profile centers. And I'm fortunate to have worked with him. And he is the founder of Department of Endocrine Surgery at CMC Vellore. And CMC Vellore is one of the very high-volume center and one of the pioneer center and one of the leading center who manages with the anaplastic thyroid cancer. So, sir, I would like to understand, you have been through this case discussion. This was an unresectable thyroid cancer, which we started after some investigation with BRAF, TERT, and other. We started with oral medications and chemotherapies. Sorry, I think it is not started. We started with chemotherapies. The patient showed response, and now we are planning to start her on some DTP regime, and which we have very good result. So what is your experience? Would you like to share How do you manage anaplastic thyroid cancers at your center? Is it the same, or is there something different? Is there some changes in the management throughout your professional career?
Yeah. Am I audible now?
Yes, sir. You are very well audible, sir.
Thank you. At the outset, I should thank you for involving me in this very interesting case discussion. It's an honor and privilege to share my experiences with all, all your expert panel who have done a great, fantastic job in managing this difficult patient. Well, if you look at our experience, I should go back to the days when the surgeon who would not operate on thyroid and who chickens out, they would say, "What? He's not a bold surgeon." And people used to go into town trying to eh, uh, trying to take out this massive swelling and ultimately ending with a lot of morbidities. So times have changed and we have moved with time. And the important thing in managing these patients is firstly make a very early diagnosis that this is probably an locally advanced carcinoma. Not to put the patient on table and try to take it out, but think. And of course, as usual, a good clinical examination is very important. Right in the beginning, once you see a large thyroid mass, which is with restricted mobility, you know this may give you trouble if you put the knife on it. So unlike olden days when we had only two options. One was when the patient usually presents with a stridor, we do a hysterectomy and a tracheostomy and give radiation. And those days, initial days, only adriamycin was available. Subsequently, we got other chemotherapeutic agents and radiation, but still surgery was not an option. And as you mentioned rightly, very few patients lived more than 6 months, and maximum we have seen with radiation, chemotherapy, and hysterectomy was less than 2 years always, never more than 2 years. But now things have changed. We have also moved with times. And now the important thing is early recognition is very important, and early tissue diagnosis. And now tissue histopathology alone is not enough. Immunohistochemistry, molecular and genomic have to be done. That is which makes things very easy. Recently, we've had 2 or 3 patients in the last 2 years where patient present with stridor, we had no choice. We debulked as much as possible, got a tissue diagnosis, got the molecular and genetic studies, started on this combination of uh, tyrosine kinase inhibitors with the PDL1 and inhibitors. And it was such a dramatic response that in about 3 to 6 months, we were able to go in again. And the important thing that we noticed here was there was a lot of tumor necrosis, and we could go in again and do a good job. With the important thing that this therapy combined immunotherapy with mutational with the BRAF mutation the blocking therapy, we have found that cases which were totally inoperable, we were able to remove them with very minimal morbidity. In the clinical examination, one thing is very important is these we know involve the aerodigestive tract, and very often some of them may present just with Horner syndrome or one of the involvement of the brachial plexus, weakness of the arm. One of the patients just presented with weakness of the arm. And once we looked at the thyroid, it was a massive thyroid which had sort of infiltrated the brachial plexus. So such patients, unlike olden days, we also, like any other center, have this tumor board where the oncologist, radiotherapist, pathologist, nuclear medicine people, all of us get together, discuss the patient. And the important thing is one shirt doesn't fit all. So we have to individualize the treatment according to each patient. So some may respond to one group of tyrosine kinase, another may respond to another group of tyrosine kinase inhibitors. And based on we have got studies which will specifically say these two inhibitors are better than this one. Not that these only one group is useful. And of course, combining immunotherapy makes a big difference. So we have we use a tyrosine kinase inhibitor along with an immunotherapy, and that really has shown us good results. So that is where the take-home message is that we don't abandon a patient saying this is inoperable, we can't do anything, go away. Now we say there is chance, there is hope, and we can try. Of course, it is not that 100% of these patients respond, but the important thing is that even with metastasis, with this therapy, we can keep the patient. The metastasis can be stasis, and the local pressure effects can be removed. And the important thing is to give a good quality of life with low morbidity. Thank you.
I think we have lost Dr. Kamboj. She's joining back. So, any other faculty wanted to share or give a comment? We can do that till the time Dr. Kamboj again comes back. There she is.
Thank you much for your insight. I have Dr. Divya ma'am with us. She is from Chandigarh PGI, who caters the patients from the northern India. How do you manage? How do you manage? So, ma'am, would you Okay. So sorry for the technical glitch. So may I request Dr. Divya Daya ma'am is with us. She's from Chandigarh PGI, and it caters patients from the northern India, and a very high volume of thyroid cancers also. They are referred to your center, ma'am. Would you like to share how do you manage such type of challenging, difficult cases at your center?
Dr. Sudhi, in my personal experience of anaplastic thyroid cancer, we have very small number, I will say. Couple of cases were in like locally advanced. Some were locally advanced with metastasis, but still we could manage to resect them. And after chemotherapy and local radiation therapy, there are like 2 to 3 years was their survival. But the cases which were unresectable, we like refer them to the radiation oncologist where they have received the chemotherapy and the local radiation. So survival was of course very little, but personally we don't have any like experience with the molecular targeted therapy because of the cost is the major factor and it has recently come in.
Right, ma'am. So you talked about radiation therapy, and we have radiation oncologist with us. Dr. Punita Lal ma'am is with us. And we know being in the eastern part of the Uttar Pradesh, and we have a lot of thyroid cancer patients in SGPJ. So, ma'am, would you like to share your experience about giving radiation therapy to such unresectable thyroid cancer? And what is your experience? Does these patients really become operable? Or how much does this radiation therapy help to these patients?
Yeah, thank you, Dr. Sudhi. It's like really you've picked a topic that has always been a point of concern as and when we get to see these cases, which is not very common, but still, I think we do get some amount of cases of anaplastic. Now, So our take is that although the biology of these tumors is much more known, now we have moleculars which we can look into, and uh, the treatment can be personalized and individualized based on the BRAF mutations and the rest of it. But having said that, overall, the prognosis still is not very good. It remains quite challenging. And a lot of times, patients come to us. We do ask our endocrine surgeons, Dr. Sabha could not join, but then because if surgery is possible, then following that, if radiation is given, it makes a lot of difference. There is a survival difference if surgery followed by radiation, whether it is R1 or R2 resection, it does make a difference. Early initiation of cytotoxics is also another thing that has shown survival difference. As far as we are concerned, we also go in early in the treatment simply because these patients have a tendency to asphyxiate because of the rapid growth that you see around the trachea, which actually compresses and uh, actually sort of eats into the trachea. So that's the reason why radiation must be instituted as early as possible. If we feel that there is some very sort of the trachea is getting compromised and there is still scope for tracheostomy or stenting, then that should also be initiated. However, a lot of times we do not get that opportunity. We have to go in for radiation. And what our practice over the period of time is that yes, we would like to give as high doses as possible, to the tune of 60 to 70 gray if that is possible. But a lot of times meticulous planning by IMRT takes some time. So what we do is that we give as soon as the patient comes and we it's been confirmed that it is unresectable anaplastic thyroid, we actually start him on, or her on palliative radiotherapy, which means we give high doses and like 5 fractions or 10 fractions, and then see the response, take an assessment again whether the patient is shown response in terms of resectability. Usually that may not still be possible. If it is, then the patient goes in for surgery. If not, then we again give radiation. This time we plan it better and try to go as high as possible, sparing the nearby structures, especially the spinal cord and all, to the extent like respecting their tolerance and going ahead up to anywhere between 60 to 70 gray. That is how we plan. But let me tell you, like most of the times we have to stop in between because the patient may not be able to go up to then the full doses of radiation. But palliative radiotherapy we institute very quickly. Our threshold is very quick or low on that.
Thank you very much, Ma'am. So I could understand because of the rarity of the disease and the aggressiveness of the disease, most of the and because these therapies are just upcoming, we really need to understand more about it. So this radiation is given for palliative reason. We have two very robust thyroid surgeons with us, and who are in a very high end tertiary centers where they operate a very huge number of thyroids and challenging cases, Dr. Vishwak and Dr. Sabha Ratnam with us, and we are fortunate enough to have them. Dr. Sabha, can I request if you can switch on your camera if you are comfortable? And he is my friend. Thank you very much, Sabha, for joining. So, and then after this, Vishwak, I will take your time to understand how you manage such cases. So, Sabha, you might have been through this case while we were discussing. And basically, we are discussing about unresectable anaplastic thyroid cancer, our approach. And this is what I want to understand from you is in HGPGI, what is the current approach in management of such cases? Are we using immunotherapy? What is our experience? What is the patients, how we manage such cases? And also, while we are planning, when we plan to operate such case, and if we are planning to operate such case, what are the pre-operative investigations that we usually as a routine look for, and during surgery, what are the various challenges, especially about esophagus, trachea, IJV? So would you put some light on all these aspects?
Okay, thank you, Dr. Sudhi. Actually, anaplastic thyroid carcinoma, it can be of three types as a surgeon. One is an incidental anaplastic thyroid cancer, where you operated a multinodular goiter or some other pathology for some other pathology. Incidentally, you found a focus of anaplastic thyroid cancer. The second one will be de novo, like de novo, and the third from an existing thyroid pathology, actually. And most of the times, when you have a patient like what I joined late, but what I could make out from your what your kind of a patient, these kind of patients, first we need to confirm the diagnosis of anaplastic thyroid carcinoma, which is not very easy actually. Sir also pointed out, Arvind Nair sir, lot of necrosis is there. Sometimes the biopsy you do, you will get your pathologist will find only necrosis. You might not get that. So doing an adequate biopsy, and even uh, I will say even more than biopsy, even FNAC is very, very suggestive of anaplastic. You find bizarre cells, squamous cells, multinucleated cells. So one should not just, for the sake of thing, directly go in for biopsy. Even FNAC sometimes can guide. And this is a pathological emergency. So you tell a pathologist, if you're suspecting anaplastic thyroid carcinoma, you need to do BRAF very immediately. You cannot wait for them to, it's like a proactive thing. And then initially we used to do tracheostomies. Now no guidelines suggest any tracheostomies first. And it all treatment modality in SGPGI endocrine surgery is based on whether it's BRAF positive or not. If it is BRAF positive, then you have, as you said, dabrafenib, trematinib, and pembrolizumab. Otherwise, the other chemo drugs. And we have, as Madam said, we have already a very good radiation oncology department, which will take care of the radiation aspect. And like we have had some patients who have responded very well. So the last part of your question. So if you operate, once the patient has responded, like not only in this, any locally advanced thyroid cancer on TKIs and as well as poorly differentiated, going in and removing is a very, very difficult thing. Lot of studies have shown lot of fistulation, inadvertent injury to vital structures. So because it becomes stony hard in many of the patients, and it's only fibrous tissue. Many a times, what you're achieving by removing those. I had a patient who had 20 to 25 centimeter poorly differentiated thyroid carcinoma. 3 years on treatment, now nothing is there. So, like now it's like normal thyroid. What you are going to remove? Should you do a total thyroidectomy in that lady? Because the mass was nodal mass, which has completely disappeared. There are studies which have shown in the last ATA they presented, if it is safe to do surgery after TKIs, you can go and remove them. And if, for example, this patient, we can do a total thyroid. There are no nodes now. There are no nodes. Like fibrous tissue, you have to remove on both sides of the neck. We have to give the option. So those things still are not much settled. So actually, we have operated a patient recently who had TKI for 6 years almost, lateral neck dissection. It is almost like you cut a stone. It's very, very hard. So actually, there to stop. And as Sarah already mentioned, quality of life is very, very important. So it's a very combined decision. We need to take a decision based on this one. But we do have a lot of experience. We have published in Indian Journal of Surgical Oncology our experience regarding TKIs, not for this anaplastic, but anaplastic also, one article has been published from
Okay, so
this one, sorry, from SGPGA, and there you will get all the how much percentage had what mutation and things. So I think I have answered. Thank you.
Dr. Sudhi, can I add something? It's okay. Like,
You just start doing it.
Hello. I'm sorry for the network issue. So, Saba, are we? Hello. Am I audible?
Yes, yes. Yeah, yes, please.
Yeah. Thank you. So, Saba, are you using this DTP regime in SGPGI? Is it started, and what is any experience you would like to share?
Recording in progress.
Which one? Sorry.
Yes. Saba is with us, right? Saba is with us, right? Saba is with us. Saba, okay. Yeah. So now Dr. Vishwak is with us. I think there's some connectivity issue with Dr. Saba. Some connectivity issue with Dr. Saba. So Dr. Vishwak is there. Thank you very much, Vishwak, for joining. These patients usually, though it is showing a very good clinical response, but we understand there will be a lot of fibrosis while we are operating. So how would you like to, how you would like to approach such case, because it is not going to be an easy cakewalk like of surgery. There will be a lot of fibrosis, there will be threat to the esophageal integrity, there will be threat to the tracheal integrity, recurrent laryngeal nerve will be at stake. So what are the preoperative investigation you would like to do in such case, and any specific precautions or arrangement you would like to keep, like for esophagus or something like that? I'm more worried about esophageal resection. Maybe from trachea we can do some shaving, but what about esophagus?
Yeah. Thank you, ma'am, for the topic that you have chosen for the discussion today. Am I audible?
Yes, you are very well audible.
Dr. Vishwak, you are audible.
Yeah. So, as you mentioned, the roadmap before surgery is by obtaining a CT scan of the neck, a contrast enhanced CT scan of the neck, and we keep things ready preoperatively, even the intubation from the time of intubation. Like we prefer awake intubation if the airway is already compromised. Second thing, we prefer the intubation tube with the electrodes having neural monitoring. So for these kind of cases, neural monitoring will be helpful to identify the entire course of the nerve if it is gets infiltrated or if it gets entrapped within the tumor tissues. Obviously, the resection planes will not be clear as how we operate the other cases, especially when the tumor is encasing the carotid or the vessels IJV. IJV we can sacrifice. Most of the time we take the cases after that encasement has completely resolved with the TKIs. There would not be an issue with the carotid. Sometimes we might have to shave off from the trachea and from the esophagus. And if required, we had taken serosal stitches on the esophagus We had not faced any major difficulties in mobilizing the plane from the esophagus, like we have not punctured or damaged the airway or the esophageal wall. Of course, the planes will be little much fibrous and adherent, but meticulous dissection had helped us to mobilize the tissue of the major vital tissues.
Right. Sir, I think we have Dr. Amit Upadhyay sir also with us. He is a medical oncologist. Sir, I think there's some connectivity issue with, so I put this question directly. Now
Dr. Sudhi,
we are
can
moved.
I add something
Yeah.
in the surgical part?
Definitely, ma'am, because I was just coming to you. Thank you. Yeah.
In my experience, like I have operated on a couple of cases of anaplastic carcinoma, which were mainly locally advanced, infiltrating the muscles or esophagus fixed to the trachea. As you mentioned, I could shave them off from the trachea, and limited esophageal resection, I think, can be safely done. Because it is in the setting of the anaplastic carcinoma. But major resection, personally, I have not done, but small segment resection and anastomosis of the two ends is feasible. And same holds true for the major vessels also, like if they are encasing carotids, we can do subintimal dissection and can like remove the tumor per se.
Right. So, Sir Arvind sir is there. Sir, we are just talking about the intraoperative difficulties that might be encountered in such patient. Dr. Vishwa put a light that we should use neuromonitors and this tracheal shaving. What about esophageal section? How do you manage esophagus? Like if there is, suppose there is no plane or there is a dense fibrosis.
Esophageal,
So what
very
is,
often
how do you manage?
very often we are able to take off the serosa, but we have a Rayleigh tube inside, so we are able to identify the esophagus nicely. There may be once you shave off the the muscular layer, we have the mucosal tube nicely. So I usually take a sternomastoid muscle and give a nice cover for that raw area. And very often, because we make sure the mucosa is intact, and with the sternomastoid, we cut the sternomastoid and invert it onto that if it is available. That usually protects the esophagus.
So would you like
Trachea,
to do?
of course. Trachea we shave off if possible. Otherwise, up to 2 rings we can easily sacrifice and anastomo straight away, end-to-end suturing.
Yeah. So this lesion is on the left side. So would we still, and there are lymph nodes on the left side, would you consider doing MRND radical neck dissection on both the sides or on the affected side only?
No, because it's anaplastic, so one chance for the first chance is the best chance. So we do a clearance on both sides.
In the first go itself.
First go itself.
So
Everything depends on, yeah. Even the carotid, very often what happens is after all this, you are able to split the tumor and sort of like an open book, it comes out of the carotid and it leaves the carotid intact.
Right, sir. So I hope all the endocrine surgeons agree to this remark. Any specific pre-operative investigation any one of you would like to do in such cases before taking such type of case for surgery?
No, usually we always do get a endoscopy and a bronchoscopy done. And we usually ask them to put a nice tracheal tube which is good. Of course, I don't have the neuromonitoring, so I don't use that, but we ask them to put a nice tube and they always put a Rayleigh tube. Sometimes it's so difficult when you try to dissect everything. Comes en mass, larynx, esophagus, and all will be one mass. So once you have a tube, you are able to identify and sort of dissect them off.
Right, sir. And sir, any specific like this CNS angiography in case the carotid is involved to the extent that we have to resect?
We have
Any take
not
on that?
had to resect. I usually try to split it and take it out, and it's very often it's only doesn't really involve the lumen as such. It involves only the peri-arterial tissue, so we are able to take it out. But if
Right.
necessary, it can always be done. We always have a vascular surgeon standby. So, and if we always have a graft ready, but we've not done that so far.
Right.
I
Thank you.
think,
Thank you
Dr.
very much.
Sudhi,
And
if the carotids need to be sacrificed, that means it is too extensive a disease. So that's why we do preoperative cross-sectional imaging and take a decision whether to give neoadjuvant treatment or do the upfront surgery. And as sir has mentioned, like by doing splitting the tumor or by doing subintimal dissection, we are able to save the carotids if we have planned for the surgery.
So,
yeah, and yes, Dr. Vishwa, yes, please.
yeah, if I could add, like earlier we were trying only with paclitaxel, then we switched it over to sorafenib, lapatinib. Those times we had ended up with the surgeries venturing into the intima of carotid, like Sir said. Nowadays, with the advent of the pembrolizumab and dabrafenib, we could see very well the tumor which was encasing the carotids. It's getting completely resolved. Now we could able to achieve a plane which is almost the planes are very clear around the carotids. And only thing is the cost problem we have, like dabrafenib or tremetinib. It's too costly for a patient. Like it's cost like 1,25,000 or 1,80,000 for tamrafenib for a single bottle. So that's the major concern. One patient I had recently treated. We treated the case with paclitaxel and carboplatin with pembrolizumab. It had responded very well. In 3 cycles, the carotid encasement had completely regressed. The tumor was reaching up to the prevertebral fascia that had reduced in size. And now we are continuing for another 3 cycles. I just want to know from Dr. Amis, I think he had left. This patient, the case that was discussed, this patient had a good response with 3 cycles of chemo plus pembrolizumab. Why he didn't continue the same chemo pembro for another 3 cycles? Why did he want to switch over to dabrafenib? If anyone could.
Actually, I think dabrafenib, because I think she's BRAF positive and TERT2 positive. So that is why they are now co-starting this therapy along with the pembrolizumab. So this DTP regime they are now planning to initiate in this case,
This patient
which
was
has shown a very promising effect.
Yeah. Hi, Sudhi. Can I mention something?
Yeah.
Hi, Doctor.
Yes,
I'm
yes.
Sushant. The the um, the scans that we have seen of December, they basically were after two Pembro, and after that she has had two more Pembros, and they have just started the Debra and Tremetinib from 16th of January.
Okay, so that is what, like when she had a partial regression with Pacli, Carbo, and Pembro, why can't we continue the same for another 3 cycles? Though she is a BRAF mutant, I understand she is a BRAF mutant. When she has a good response, we have an option of continuing the same. That is my query. The other
So I
way
think
is like,
yeah, I'm sorry to
sorry.
interrupt. He has already mentioned in his presentation that because with this therapy he has a very good clinical response, so we really don't want to interrupt this therapy. I think he's continuing with this therapy, And along with now the report has recently arrived of that she is BRAF positive, so he will add this therapy also, with the possibility and the prediction that possibly we will get much better response in another few months.
Yeah, obviously the response will be much better, and especially these dabrafenib and trematinib, they had been shown to improve. They have been shown that 60% of patients, you know, they had been converted to radioactive iodine sensitive. Usually, the dedifferentiation when it happens, the tumor it become radioactive iodine resistant. But these MAP kinase inhibitors have shown to re-stimulate the sodium iodide importers, and nearly 60% of these patients will have radioactive iodine sensitivity. So that can be used as a part of adjuvant scenario when they become so. This has a definite role in it. Before this, we were using sorafenib and lapatinib, but with the advent of this, we are seeing promising results. And I have a small query with
Yeah.
Dr. Chani. In this scenario, when a squamous cell is being encountered in a neck swelling, what did she had done any IHC to rule out squamous cell carcinoma from the upper esophagus?
So this was an outside reported case, but otherwise, immunohistochemistry with the help of PAX8, we can differentiate from a primary thyroid uh, SCC from SCC extending from esophageal or oropharynx or any other site. Actually, there's a combination of markers, but PAX8 is a especially useful one.
Okay.
So I think PAX8 was not done in this case.
In this case, P53 mutant it was there, and because of that, and right, P63 was there, and P53 was mutant type. So
Okay.
because of that,
Yeah.
I think
just
they
want,
opted
yeah.
for a
And not every centers have a PET scan. Like we have to have our basic histopathological and IHC findings, you know, more relevant to the diagnosis.
yes, sir.
Right. So, thank you very much. Now we are just at the end of our presentation, our this today's presentation, and we had a full 1 hour discussion and didn't even realize the time. Thank you very much for this thing. And in today's presentation, we discussed from tip to toe each and every aspect of anaplastic thyroid cancer, which is a very rare disease, I must say, and but very challenging to the surgeons, to the medical oncologists and the radiation oncologist who manages thyroid cancers. So we discussed about how we should diagnose, what are the preoperative, what are the investigations once these patients come to us, how we should plan the therapy, what we were doing earlier, what are the recent advances, what are the results of these recent advances, the newly introduced drugs, and with some case examples we try to understand. And I think now many of us, all the participants, will try to inculcate this protocol into their practice also, and will see the results themselves. And definitely cost is a limiting factor, but we talked about the molecular therapy, immunotherapy, which looks promising. We talked about the surgical aspect, the various challenges that we as an endocrine surgeon see in such cases, what are the pre-operative investigation that must be done. So each and every aspect we covered. I hope if there is any quick questions we can address. Otherwise, I would like to say thanks to all my participants. Is there any question?
Sudhi,
Right.
one small this one, because it's a very rare disease, anaplastic thyroid carcinoma. Tissue banking and combined approach, like Indian Association of Endocrine Surgeons coming together and getting everybody's experience and publishing guidelines for Indian anaplastic thyroid carcinoma. Because as it was pointed out, like 3 lakh to 3.5 lakh rupees for a month for 3 drugs like roughly, it's many patients might not afford. So those things also need to be taken into account. Thank you so much. And sorry I couldn't join early.
No, no, no.
And
Anytime,
Dr.
join.
Sabha, the Pembro is associated with lot of side effects as well. Its cost is one factor, but the side effects are also a lot. So to continue it for long, like we really have to weigh the risk and benefits.
Yes, ma'am. I totally agree with you. Actually, like we tell three drugs, like we had patients like who have responded, and like two diseases, adenocortical carcinoma and anaplastic thyroid carcinoma. The tumor doubling time is so fast. Whatever you do, it comes back again, and it's very difficult for the treating physician as well as for the patient and the family. Like we have to counsel that as well, actually. But very nice points
Okay.
you told about the surgery. Actually, I also agree with you. Esophagus, we didn't have a problem, but pharyngeal injury, pharynx, we had two or three patients, which was repaired with the Riles tube in situ, and then we removed. And one more finding I will, which I found was uh, all these vessels had mushrooming thrombus inside most of the times when I operated either a poorly differentiated or anaplastic, that classical finding was there. You can see the tumor coming into the vessel. So that was one interesting finding. Thank you so much, actually, everyone. And
Regarding side effects that we discussed about, so Dr. Sushant is with us. So would you like to share, Sushant, any specific side effect, any bothering side effect with all these therapies?
Yes. While she was only on chemo and Pembro, we all know about the side effects of the chemo. But with Pembro, because she's already having a bit of a history of fatty liver, uh, alkaline phosphatase, SGOT, SGPT, they went quite off. So that's why it was quite critical to maintain that gap of 21 days between two dosages of immuno. But luckily, she's doing fine there now. However, she's struggling a bit with BRAF inhibitors right now. It's mainly a lot of lethargy. Pyrexia hasn't been there much, but her appetite has gone down. With immunotherapy, when she was on immunotherapy only, her appetite actually got better. But with BRAF, vomiting and dizziness is there, and yes, a lot of lethargy. Uh, that is what she's struggling with currently, uh, and that's what we are struggling with right now. But yeah, we are onto it. We are working there.
Really bothering compared to the disease that we have?
Sorry.
Are those side effects really so bothering compared to if we compare with the
No,
disease
no, no,
those are
definitely
manageable?
not. Definitely not. Look, once we showed her the pre PT PET scan and the post PET scan after two immunotherapies, her morale and her hope really went up. Um, but in total, if we look at things, no doubt the side effects are nowhere near than what initially she was struggling with. She herself is finding, there is no problem with the swallowing has gone back to normal, that's all good. There is no fever, nothing there with BRAF. Only thing with BRAF is uh, basically lethargy, dizziness and vomiting.
Right. So I hope this was a live example of the side effects, or most of them who are apprehensive, so they can compare whether.
I have one question though. I'm not from I'm a dentist. I'm not from this field, but I just met one patient yesterday of mine here in Australia, and he's been taking BRAF inhibitors, but for melanoma for last 3 years. And we were talking about resistance coming, and his melanoma is obviously haven't checked the reports or anything, but he's been taking BRAF for last 3 years, Debra and Trametinib. So is it like with Debra and Trametinib, this resistance is only seen in anaplastic thyroid carcinoma, or is it like I was
It is
not
with any
very
it
sure
is with
about it.
any
So
cancer, Sushan, because these cancer they find their own ways to overcome these resistance. So this is with any other. So usually we combine the medicines. So now, because since we have a lot of questions still pending, but time is a constraint, and we have successfully completed this presentation today. Learned a lot of things from each other. Lot of point now. I believe that most of are in a better position, much more intelligent in dealing such cases. They can provide them more options, at least when these patients present to them. And with this, I would like to thank Dr. Arvindan Nair sir, Dr. Punita ma'am, Dr. Sabha, Dr. Divya, Dr. Amit Upadhyay sir, Dr. Vishwak, Dr. Chani, and Dr. Amish for making this presentation possible, making this discussion possible. Without them, it would not have been possible to get so many insights from so good centers, high volume thyroid cancer centers across the country. I would like to thank Dr. Sushant for bringing up this case into our notice and giving us this opportunity where we can study this case in detail and discuss about it to learn many things about anaplastic thyroid cancer. I would like to thank all the participants who remain patient throughout the presentation and listen to us. And I hope they will take so many messages with them and they will do better in their field at their places. I would like to thank all my team members who at a backstage helped me to present this case, to get all of you on board. And they are my backstage power, I must say, who helped me in bringing BRENDOS every month in front of you all. And with this, I would like to say thanks once again. And this program is being recorded every time we record these programs, so there's no need to worry, because this is something very invaluable. I don't want to get it lost. We record all the presentations and we upload it on YouTube. The link will be provided shortly within few days, and you can access all these discussion anytime if you wish to. Next month is an even month, so we will plan to have a breast related discussion. Anyone who deals with breast disorders, please stay connected with us. We will be sharing the details soon. And certainly we are going to discuss something very, very interesting and very pertinent to the clinical practice. And a few words, if all the any faculty of you would like to share with us, that would be encouraging to our team members and for me as well. Thank you, sir. Anyone?
Thank you very much, Sudhi. This session was really very illuminating and give us a lot of insights into various aspects of management and the impressions of various people who are in the field. Thank you very much for this very nice thing. And the program that you are doing is very encouraging and very enlightening for all. Thank you very much.
Thank you, sir. Thank you very much.
Sudhi,
Thank you, Dr. Sudhi. It was really wonderful presentation and the discussion as well. Thank you.
Thank you.
Thank you, ma'am. Thank you very
It's
much.
very impressive what you do to hold everybody's attention for 2 hours and have such interesting and extensive discussion. It is amazing. It's truly impressive. Thank you so much.
Thank you very much, ma'am.
I would like to also thank Sudhi for doing this and bringing so many esteemed guests on one platform. I'm really thankful to you, Sudhi. Thanks a lot. Thank you.
Thank you very much.
And to Dr. Amish as well for taking care of my mother. Thank you. Thanks a lot.
Thank you all.
Yeah.
Thank you all.
Thank you very much.
Thanks a lot.
And with this, I request you can now exit this meeting, and with the promise that we'll stay connected with some very interesting topic next time. Thank you, sir. I'm closing this meeting. Thank you. Have a good night.
Good night.